Good evening. Welcome, everybody. Thank you for joining our EdgePRO Summer Series Part 3. We look forward to having you all here tonight as our third part in a series of great conversations with Dr. Charles Maupin, Dr. Craig Anderson, and Dr. Jacob Butler around the value of laser-assisted endodontics, specifically with the EdgePRO technology, Erbium Chromium YSGG. Tonight, we're going to focus in on predictable outcomes in challenging cases. So we've heard a little bit about the why in terms of why we look to incorporate laser-assisted endodontics into the field of endodontics. We talked a little bit about the how and specifics around mastering some technique and extending applications with EdgePRO. And we've gotten specific on some of those techniques, and certainly we want to continue to answer any questions around that. So tonight, each of our panelists will focus in on some unique cases that they'd like to showcase that maybe delivered an exciting or predictable outcome, maybe that they otherwise might not have expected, even though each of us here does great work, in addition to all of you online here tonight. But we're pleasantly surprised by certainly what they found either during the case or as a result of looking at the outcome post-procedure. So we'll start the presentation. Each of our panelists will go through some cases. We would ask that if you have questions pertaining to any of these cases, let's ask those questions after each panelist presents so that we can remember those questions with regards to those specific cases. I know sometimes that can be a little hard to do at the end of the presentation. And then at the end of the presentation, if there are more additional questions that we need to ask, I know we've got a great audience of both users of the EdgePRO technology, either have just gotten started or kind of are midway into their experience, if you will, with the technology. And then we have some others that are interested in the technology and are seeking more information and really trying to better understand the capability of incorporating a technology like EdgePRO. So we want to make sure that this is valuable for both of these audiences, and a lot of that can be achieved through some of the questions that are asked. So we really do urge questions throughout this evening's presentation. We welcome you. I'm now going to pass it over to Dr. Craig Anderson, who's going to kick us off here. Thanks so much, Dr. Anderson.
All right, thank you, Chris. Hey, everybody. Thanks for joining us here at the end of another week. I'm going to present tonight 5 cases, all of which, nothing necessarily special about them, but they each kind of highlight maybe a different reason why I think the laser can bring value, and how maybe I had some questions last time about the general wave and how I decide, and maybe touch on that just a little bit. So I'll present 5 cases that kind of outline some of that, and then I also have another case at the end that we'll do a little compare and contrast with some general wave stuff as people were asking questions last time. Okay, so let's see here. We'll start here with our case 1. This is a case, number 12 here, deep composite filling. This tooth presented necrotic with symptomatic apical periodontitis. You can see periapical radiolucency. The 2D imaging doesn't look really very interesting. You wouldn't know that much was going on. But when you take a look at the cone beam, you can see just a little bit on the cone beam slice here. Maybe something weird's happening through the mid root. When we look at the axial slice, you can see it's a really interesting anatomy. It's kind of somewhat of a C-shaped canal. We've got two small buccal canals, little connection here, just a very delicate root form. So this is a case where, I know that I want to keep things really small. I know that there could be challenging areas where going too big could become problematic, either for strip perforations or instrument separation. But at the same time, I want to do this case in one visit. I don't want to have to medicate. I don't want to have to feel like I can get it clean in one sitting without having to let the medication work. So going into this case, after seeing the cone beam, I knew that that this was a case that I really felt like I needed some enhanced irrigation of some degree. And this is what we were able to achieve. Okay, you can see when you look at the post-op, you see a lot of, it comes to light what's going on in the mid root of this tooth. There's actually it's not one canal splitting into three and coming back. It's two canals on the buccal and one canal on the lingual. But you can see we were able to achieve patency. We got some nice accessory anatomy. I was able to do all this without too much risk of over enlarging the canals, but yet clearly got nice clean at the end. When viewed from the off angle x-ray, you can see I finished these cases at 2004 for all canals, even though it looks a little bit smaller here on the buccal. I would not have been confident to do this in one sitting with the amount of mechanical instrumentation I did to this case. The next case is kind of just a case that will highlight some accessory anatomy. This was a tooth number 30, presented with as necrotic with symptomatic apical periodontitis. This case was also completed in one visit. You can see a large focal kind of blowout radiolucency on both roots. Nothing on the 2D imaging that would make you be too interested that anything much was going on. When we look at the 3D imaging, you can see through the distal root here, we've got kind of a separated foramen here on the distal. If you look at the axial slice, you can see on the mesial, it's kind of a ribbon-shaped canal. You got kind of an obvious main lingual and buccal, but also some communication between the two. And this is what we were able to come up with. This is just a straight angle X-ray. You can see nice length control in both roots. A little bit, what looks like a little bit of accessory sealer out of a canal, but when you change the off angle, you can see a lot more is going on in both roots. Actually, in the distal, you can see a little bit of deep isthmus. In the mesial root, all kinds of communications between the main mesial buccal and mesial lingual. On the post-op CBCT, it becomes much more clear exactly how much is going on in this root. So again, this is a tooth. When I was doing the case, I was just all over the place. I kept hitting roadblocks. I irrigated and used my laser multiple times. I know for sure, had I not had the laser at my disposal, I would have not felt comfortable doing this case in one sitting. The third case I did actually this week, maybe, or late last week. This was a really interesting case, and this is one of the cases I mentioned where I can kind of contrast my laser experience with my general wave experience. This case presented as symptomatic irreversible pulpitis, symptomatic apical periodontitis. Okay, again, nothing about the 2D imaging is very interesting, but when you look at the 3D imaging, there's something going on here on the furcal side of the mesial buccal root. You can see the main canal here, but even on the 3D imaging, it was not perfectly clear what was happening. I just knew it didn't look quite right. When we change to the axial slice, you can see the mesial buccal root here with two canals, palatal root here. But again, this furcal aspect of the distal buccal root, something is going on there. So this is a case where I didn't, if I was going to try to use gentle wave, this might be a contraindication. Not necessarily that it would cause a problem, but for me, with my risk tolerance, I would not necessarily want to use the gentle wave without knowing what this is and what some of the possible outcomes would be if I got that, if I ran a cycle. So I didn't. I think that's one of the pluses of the laser is that I can titrate my treatment. If I want to just treat the mesial buccals or just treat the palate and leave the distal buccal alone, I can do that. Okay, so that's what I chose to do here. I actually ended up running, when I got inside the canal, there was not a big defect. There was no bleeding. So I did end up using the laser not only on chamber mode, but into the canal without any problems. But I wouldn't have felt comfortable doing that with gentle wave. Okay, and this is what we came up with. Nothing real exciting about this post-op image. But when you look in a little closer, you can see not only did we get some nice anatomy on the palatal root, but something is going on on the wall of this distal buccal root. I don't exactly know what. Patient's aware that I'm not exactly sure what's happening, but we cleaned into it. We've got sealer in it, and we've given the tooth a chance, and I was able to do it comfortably for the patient without any concerns on my part that I might cause any unexpected damage. The fourth case is another unusual anatomy case. This case presented as necrotic with symptomatic apical periodontitis. Okay, cone beam shows maybe a little more extensive damage here and a lingual positioning of the root. All right. Again, similar to the other case, the distal root's got this kind of C-shape-ish anatomy to it. You can see one really broad distal canal. If you look at the slice over to the right of the screen, you can see that while it may start off as one, it goes to two at some point down the canal. So I knew going in this was going to be a very challenging case to clean into some of these deep isthmus areas, and not wanting to over enlarge my canal, because if you look here, the invagination on the furcal side of the distal wall really doesn't leave a lot of room for air for over enlarging the canal. So I wanted to keep things as small as possible. And this is what we came up with. Okay, unlike the case I showed earlier where I was able to navigate more fully with true canals and make more paths down, this one I wasn't as able to do that, but I was able to get pick up lots of accessory anatomy in that distal root, and I was able to complete that in one sitting. The last case I'm going to show here is a case with severely calcified canals. All right, tooth number 30 here, presented as necrotic, asymptomatic apical periodontitis. You can see very standard lower molar anatomy, lesion on the mesial root, very faint canal present on the 2D imaging. If you look at the bite wing especially, you can see just really kind of a block of dentin there. Okay. But after lots and lots of long visit, tons of hand files, multiple rounds of using the laser, I'd get down a little bit, I would peck and peck and peck and make my way, enlarge a little bit, run the laser, run the chamber. I'm not sure that I had to have the laser to achieve the unblocking of the dentin and make my way to the end, but I do feel like it helped and made the treatment made a difficult case manageable, or at least help expedite the process. Okay, so you can see a little bit over enlarged by kind of what I like to do, because we were doing some searching for canals up here in the top, but in the end we were able to keep a nice conservative shape to the bottom, and we were able to obviously get very nice patency on a difficult case. This is the other case I mentioned. This is actually a general wave case. Chris may not want me to show a general wave case, but I think it will make for a nice comparison, because what I get asked a lot is, how do I pick which modality I want to use, general wave versus edge? And what's interesting is you can never do the same tooth twice, right? You can't do it once with general wave and then once with laser and see which one you like. But I just so happened to do this case, and in the very next case literally was this case. And if you look at these teeth, they're almost identical, right? You've got crowns on them, you've got very calcified canals, and you've got a lesion on the mesial root. This one actually has lesions on both, but in 2D, they look like the same tooth. So this is probably the closest I've ever been able to come to doing the same tooth twice, and it happened back to back. So I thought I was really excited. So I did one with laser and one with general wave. And you can see the results are very similar, right? This is the general wave result. Very similar. Look at the top, kind of the same troughing patterns, a little bit bigger shape at the top, and then very delicate anatomy at the bottom with some nice patency. If you were to compare these two teeth, again, they're not exactly the same, but they're pretty darn close. You can see that the result is basically the same, and I think that's what all clinicians are trying to do. We're trying to compare technologies and see which ones work best. And I know those are questions I get asked a lot. And I think there's maybe this idea out there that general wave cleans better, right? I think it cleans great, but I think the jury's probably still out on whether either of these technologies clean better. I think the reason I'm showing this is to kind of definitively make the point that they both work great, and that there's no reason to think that laser is some some technology that's is not as good as the gentle wave. So I just thought that was a nice compare and contrast. So that's all I've got. I'd love to take any questions. If anybody has anything about any of these specific cases, I'll be happy to scroll back to the case in question, and we can maybe highlight some of the answers that are needed.
Great. Thank you, Dr. Anderson. Great variety of cases. And yeah, we really do appreciate you showing the differences between technologies, and that's what this is all about, is to show how they can certainly demonstrate comparable outcomes, which is great here, and for you to have that experience is really that's very helpful. There are a couple questions. Number one, on case 2, you mentioned several roadblocks throughout the case where the laser helped you. Can you speak in a little more detail about how you use the laser to address those roadblocks?
So this case, I think this is the one in question. This case is actually a little older. This is maybe 6 months ago, something like that. And I'm still in my learning curve with laser for sure, but I was a little bit less versed when I did this. As far as my memory goes, this would have been a lot of chamber mode, a lot of using the the number 3 tip in the chamber, just creating energy into that system. Even with my skills now, I don't know that because of all the roadblocks here that I would necessarily be wanting to put the laser tip too deeply in there, for fear of, even with my hand instruments and with my rotaries on this case, I was almost every time I would put it in, it would go a little different direction or hit something. So I was very weary of where I was putting my instruments and the risk of fracture with just mechanical instrumentation. So I didn't want to do that with the, certainly with where I felt like I was in my skill set with the laser. So this was mostly chamber, pick, try rotary, get down, go back with the laser, just to kind of keep force and irrigant into the areas beyond where I'd cleaned so far.
Right. Another question here is, in regards to the cases where the sealer extends into the apical ramifications, how close to the apex did you take the laser?
As I mentioned last time, my general rule is I generally try to set the stopper on the laser roughly 5 millimeters from the apex. That's just my general rule. So, usually, most cases are going to be 21 to 19, something like that. And so usually I've set that tip for 14, 15 millimeters, depending on the size of the canal. I may go a little further, but roughly, 4 to 5, 6 millimeters from the apex.
Great. In terms of treating these cases in one visit with the laser, can you discuss if there were any post-op complications, pain, or swelling?
Certainly no complications that I have noted. As I mentioned last time, not the whole thing, but one of the reasons I explored this was to try to transition to a one visit and practice both with general wave and laser, and that came with a lot of fear. I was a 2-visit guy for over 10 years, and in my general dentist years, and so that came with a lot of fear. And at first, I think I gave credit to the technology as to why I wasn't having more problems with one visit endo. I'm not sure that's totally true. I think part of the one visit model is maybe not as scary as I once thought it was. But no, I've not had any what I would call problems. I would say my post-op sensitivity and pain is basically the same as it was before. Before I went to one visit. Short of, I probably am getting less flare-ups now. Again, I don't want to give too much credit to the technology. I think I'm realizing more through just personal experience and from mentors like Charles that I think calcium hydroxide is the culprit for a lot of the flare-ups that I see. And so now that I use less of it, I think I'm getting a few less flare-ups. But certainly has not gotten worse. I certainly do not get more, bad care calls or bad post-op, things I have to deal with since I've switched to one visit.
Great. A couple more questions. Great cases. Do you have any cases with recalls? Have you noticed better and quicker healing with the laser?
I have more recalls on Gentle Wave because I've been using it longer. My recalls are starting to roll in more on laser. I'll speak to both technologies. I think that's one of the big things that's touted, especially by Gentle Wave, is that you get accelerated healing on imaging. I have not necessarily found that to be true, but I'm not one that, I do a lot of recalls, but I'm not painstaking in my follow-up and taking tons of post-op CBCTs to perfectly assess the rate and the extent of healing. I'm a little more pragmatic than that. So I can't say for sure that any of the technologies have rapidly increased my healing. No.
Do you prescribe antibiotics when you treat teeth with large radiolucencies using the laser in one visit?
Generally not unless it's Friday afternoon. No, not unless there's some other factor that has me concerned that I would need to. No, not particularly.
Great. Well, these are great questions. Please keep them coming. We're going to go ahead and transition on to Dr. Butler. Thank you very much, Dr. Anderson, for sharing those great cases. I'm sure there'll be some other questions as we go through throughout the rest of the presentation here. But thank you, Dr. Butler. We'll pass it over to you now.
All right, great. Thanks, Dr. Anderson. Great cases. Thanks everyone for joining us again. I know this is the third in the three-part series of this summer series from EdgePRO. So thanks for sticking with us to the end. Really looking forward to sharing more cases today. And thanks again to Chris, and we got Zach behind the scenes kind of helping us out. So I really appreciate them. And also you'll get to hear from Dr. Muppin here in a few. So I won't take too long. For those that were here last time, I talked a lot about my experience with why I incorporated EdgePRO into my practice, some of the concerns I had in starting to implement its usage, and kind of how my philosophy and the way I treated using EdgePRO evolved over the last, it's been about a year now, a little over a year actually. So it was last September, the beginning of September, that we started utilizing EdgePRO in our practice. So today's, it's going to be a little bit different, similar to the cases presented by Dr. Anderson. So we all know endo works. I mean, that's why we do what we do. That's why we do root canals for a living, because endo works, and it works most of the time, thankfully. But there are those cases, they go through all of our practices every day that are iffy. We look at them and we study the CT scan and we talk it over with the patient, and we say, things like, this case, it may or may not heal. There's some things we can try. Don't get your hopes up. Those types of things. We've all been there. I want to present a few cases like that where, it may have been a little bit more of a toss-up, or maybe more of a, in certain cases where I would have pushed the patient to consider, maybe replacing the tooth in certain instances, where the EdgePRO has given me increased confidence to complete these cases and follow the cases and hopefully have a better outcome as we follow these cases long term. I listed, I'm not quite as active on social media as the others, but I did list my, so I started an Instagram page here. The reason why I placed this here isn't so that you'll follow and comment and things like that, but it's so that you can reach out with questions if they come up tomorrow or down the road. Sometimes it's a little bit hard to, I know I've been there. You hear from a presenter and they present, and then the next day you say, oh, I wish I would have asked him this, or I wish I would have asked her that. And so you can send me a message there, and I'd be happy to help you out. Even if we need to, talk on the phone or something. I love teaching what I do and sharing the little bit of knowledge that I've gained with others. So please reach out anytime. Let's see here. This is my first case here. I entitled it Large Lesion. It's kind of this case is a little, it's more interesting than most to me because it's my main assistant's family member. And so this lady presented with this large lesion associated with this upper incisor. I mean, it's just massive. I didn't put the CT image on here, but it's even larger than it looks here on these two-dimensional images. It's actually broken through both the cortical plates on the buccal and the lingual. Just huge. One that I normally wouldn't anticipate would heal with non-surgical endodontic therapy. Usually these ones, at least traditionally in my practice, these ones end up getting a root canal and then apico shortly after. This one, because I know the person and because we have the EdgePRO laser in our practice, I presented the idea that we would do the retreatment and that I would run the laser at all the way kind of hubbed out as far as it would go with water to try and kind of pump the laser energy into the large lesion out the open apex. So patient agreed, and we've been following the case now for a few months. Let's see, this is the last image here I have is my 8-week follow-up. So I guess we're probably due for another one. It's probably been another 8 weeks since then. But during the procedure, after removing the old gutta percha, I got a little bit of separation from the lesion, but not a ton until I started using the laser. And then once the EdgePRO was activated, I just got all kinds of just fluid and gunk and separation out of that huge lesion, as you might expect, followed by bleeding from agitating the tissue that was there beyond the root. And so I don't know if it's going to work. It's still too early to tell. But I can tell you that the patient is asymptomatic, and she had been very symptomatic for a long time, especially just palpation, just touching up there. She always knew it was there. It wasn't ever like a severe pain for her, but she always knew that it was present. And within a short time, I mean, we're talking a couple of weeks, she said that the discomfort had gone away. And so we're just kind of just leaving this one alone to see kind of how it responds. The idea behind running the EdgePRO beyond the end of the root is to basically I was just trying to disrupt anything that I could. Similar to how we do it when we do apicoectomies, where we curette and we scrape and we try and disrupt everything that we can and remove everything that we can in order to stimulate the healing of the tissue. And so that's kind of something that I was trying to do non-surgically by incorporating the EdgePRO. I did it in one visit. Normally, I would have, had I attempted this non-surgically before, I would have used probably Vitapex, calcium hydroxide of some sort. Usually we use Vitapex. I would have probably recalled the patient several times and replaced it over and over and over until we started to see some bony healing. But this one I did differently. Patient was okay with the experiment, for lack of a better term. And so I hope to be able to report some good findings on this over the next several months and years. This is case 2. So this is how the patient presented to me. This tooth had already had a root canal and it had had apicoectomy as well. And so you can see it better on the axial slice of the CBCT, but there was definitely evidence of probably an MB2 here. Just kind of this lesion. You can see this bevel from the apicoectomy, so it wasn't kind of maybe wasn't resected as well as I would have liked. I didn't do the surgery; it wasn't done in our practice, so I don't know the circumstances behind it. But it had been done many years prior. The patient didn't even remember when. The root was already short, so we talked about, well, do we go back in, do another apical? The patient was really adamant about trying to save the tooth. I talked to the patient about the EdgePRO. I said he was a really great guy, really interested in learning about what it was that we were going to be doing differently from what had been done before a number of times on this tooth. And so I presented the option to utilize the EdgePRO to treat the tooth non-surgically. And so tooth also had a sinus tract, as you might imagine, from that lack of the buccal cortical plate there. This is the post-op x-ray over here on the right. This is the pre-op. So I actually, I treated the whole tooth, not just the mesiobuccal root. We found MB2, and I also treated MB1, and I was able to, I don't know if I don't know if I just pushed the old root canal filling that was in there, the filling that was placed during the apicoectomy. I don't know if I just like pushed it out into the lesion or what, but I was able to get patency pretty easily. Maybe it was soft. And so I treated the entire tooth with the assistance of the EdgePRO laser. I have a video that I want to show you because I also, so I used tip 1 to disinfect the root canal system here as part of the root canal retreatment. But I switched, after we were finished, I switched to tip 3, and I got just kind of a quick video. I had my assistant do it with her cell phone here. So it's not the best quality, and we were kind of moving around a little bit, but I'm going to show you how I was just kind of running the EdgePRO laser with tip 3, just at the preset settings, no special settings or anything, into the sinus tract. Looks like the sinus tract, after looking at it now, kind of had a couple of exits. And you'll also see, some sealer. Maybe it was my sealer, or maybe it was, part of what was left behind from whatever I pushed out from the previous apicoectomy. But you actually see some of that kind of coming out here once the video runs. So I would just kind of insert it, fire the laser, and then just pull it out slowly. And you can just kind of see, we're just kind of getting some kind of that gunk coming out, some sealer or whatever it is that's coming out. And then at the very end, I just kind of turned the tip 3 sideways and just kind of ran it right over the top. I think Dr. Maupin it was, or maybe it was Dr. Anderson, had mentioned that at our last meeting. So I tried that on this case, and it seemed to work out very well. This was just like last week, so I don't have any follow-up here, other than we called the patient a day or two ago to check to see how he was doing, and all the symptoms had gone away. He said that the sinus tract, the bubble on his gums it was gone. So I don't know if it's completely closed up. It's probably a little too early to have complete closure, but at least he is asymptomatic where he was symptomatic before, and he feels like the sinus tract has gone down on that tooth. So kind of a cool case, one that I definitely wouldn't have approached with confidence had I not had the EdgePRO to assist me. Dr. Anderson presented a case similar to this, one with delicate canals. This one looked pretty similar to his, 2 buccal canals and a palatal canal. I finished this one at a 20.04. I didn't really get any crazy anatomy that I can see on here, but I was able to keep the shapes very conservative, super conservative compared to what I used to do. I would open things up mechanically just to be able to have confidence that this tooth was also necrotic, but just to have confidence that I was properly disinfecting with the irrigants. So I did my kind of normal protocol and ran the EdgePRO to about mid-root, just went through the sequence and the hybrid sequence, the preset settings, and I got a really nice result by keeping things nice and conservative and not worrying about opening things up too much and risking a strip perforation or something like that. I just have one more case. I briefly presented this last time for those of you that were here. This is something that I'm just kind of starting to dabble in now, and it's kind of like an internal repair of external resorption. You have to have kind of the right case for this. Not all resorptive cases are able to be treated like this, kind of from the inside. But this one, I thought we would give it a try. Necrotic case, kind of just ran the EdgePRO sequence, and this the resorptive defect, as I mentioned before, it was full of just soft tissue that had overgrown into the lesion, and just by running the EdgePRO with water, it just got rid of all of that. I was just using tip 3 in the chamber and just kind of letting it go. I just was holding it there passively and running the laser with a lot of water and suctioning. And honestly, I've never seen resorptive defects so clean. It was just, I wish I had the capability to snap a photo under the microscope. I don't have that set up just yet, but super clean. I felt comfortable restoring it from the inside. So that's all I have as far as my cases. Happy to turn it back over to Chris and answer any specific questions that there might be before we turn it over to Dr. Maupin.
Thank you, Dr. Butler. Great cases, also great variety and really showcasing the utility and value here. Couple questions. What is your EdgePRO settings for beyond the root end?
I just for beyond the root end, I only use water. So I use the water setting, and it's just the preset. So it's tip 1 that I use, and maybe the others can chime in if they have another way of doing it. But I use tip 1, the longer one, and I just use the water, and I just basically push the filament as far as it'll go, and then run it. So pedal to the metal and let it run with water on the water setting. So it's the, let's see, I guess it's called the hybrid sequence, and then the second one. So on hybrid, you've got like the conditioner, the chamber conditioner, and then you've got the second one is the water, I believe. So
yes, it's the first part of the hybrid. So you'd use that second step after preconditioning, which would be the water.
That's right. Yeah. And so with mine, I've never, and then with the sinus tract with tip 3, and I don't know if this is something that the Edge rep Chris Bailey set up on ours specifically, or if they're all set up like this, but I have in my settings, like in my custom settings, I have one that's for like gingivoplasty / sinus tract or something like that. I should have written down the exact settings. If you don't have that on your EdgePRO and you need it, message me at that SipSap save, and I can get you those exact settings, send you kind of maybe even a video of our kind of how you get to it, something like that. So.
Yes, and we can also provide you more information. We have all your contact information for all the registrants. If you have specific questions, we can get those questions answered, specific obviously to EdgePRO users that have questions on certain settings, but in addition to folks that are exploring the technology in more detail. Well, great. Let me. We have another question here. What other settings to use? You might have asked. You might have addressed. What are the settings to use in the sinus tract? Type, size, power, water.
Yeah, so again, just to kind of hit that again, so I use tip 3, the shorter, thicker tip, and then I have a setting in mind, and I don't fool around with the settings much. I have the kind of the presets, and I just run with those. They've been great for me for the past year, and so I have one again that's for sinus tracts. So it's certainly high powered, but I don't know the exact hertz and wattage and all that.
Charles, were you going to chime in there? I didn't want to cut you off. I'm sorry on responding to any of that.
Yeah, so the standard perio settings, anytime you're doing a perio pocket, and I consider sinus tract that as well, it's 1.5 watts, 30 hertz, and you're going to have your water on and your air around 20%. So 1.5 and 30. And like Jacob said, the number 3 tip, you don't want to use the number 1 tip in there. It's too delicate. You'll put it in and you'll break it. And then going out the root end, I would do the same 1.5 and 30 out the root end as well.
One last question before we pass on Dr. Maupin here. Dr. Butler, what's the rationale and mechanism of your extraradicular use of the laser?
Say that again. My rationale and mechanism.
Rationale and mechanism is the question of your extraradicular use of the laser.
Yeah. So again, and I talked more about this last time. I'm definitely definitely more of a clinician than an academic here. So for me, I'm trying to disrupt something that doesn't want to be disrupted. Biofilms, bacteria, cystic lesions, granulomas, whatever may be causing disease in the periradicular tissues, I'm trying to disrupt that with laser energy. That's kind of as simple as and the extent to where my rationale goes.
Fair.
Did that answer the question?
It did.
Okay.
Very simply. Well, great. Well, thank you again for sharing your experience, great cases thus far, and appreciate all the great work that you're doing. For those that have additional questions, please continue inputting them into the questions area on your screen, and we'll get those answered. We'll go ahead and move on to Dr. Maupin. Charles, are you ready? Pass it on to you.
Yeah, it looks like I'm frozen. Can you hear me?
We can hear you. Maybe we can pass over there we go.
Can you see me now? Or can you see the screen?
Yep.
Everything's good?
Everything looks good.
Good. All right. Hey, thanks, Craig, and thanks, Jacob. You know, on the extraradicular, it's something that, you know, a few of us kind of joke around on, you know, going through sinus tracts or into something like that. We term it the either poor man's APICO or lazy man's APICO. And exactly what Dr. Butler said, you're just going in there just to try to disrupt it, try to avoid going, you know, under the knife. And, you know, I'd say it works sometimes. It's not successful all the time, but sometimes it does work. So I think there's definitely some validity to it. You know, that's what perio is doing when they're going in there down the perio pockets. They're trying to disrupt that granulation tissue, break that up, and get some reattachment going on. But anyway, Chris, thanks for the time again. And you know, the first two webinars we focused on, I shared technique, showed a lot of videos, showed how to incorporate the EdgePRO. This one's going to be a little less cognitive load, and mainly just what I wanted to focus on is just how I use it to treat the quote elusive MB2. And so we'll start off with this case here. This was a 6-month recall that was actually in the office today. And so I chose a few cases from this week, kind of put them in, and then a few other ones that I'd had. But this case was in for a 6-month follow-up today. Treated both 13 and 14. This was the pre-op on the left, post-op on the right. And you can see we have 4 canals treated to their full apical extent on the number 14 there on the post-op image. And we look at the pre-op CT. What we see on the pre-op CT, it looks like there's definitely MB1 there, and it looks like there's probably an MB2 somewhere. It meets up and then splits apart again going on there. And we took this was the 6-month follow-up CT. I didn't take a post-op CT. Don't do that much unless I want to show something here, but occasionally we do. But you can see that we replicated the pre-op anatomy present in our follow-up CT there. So canals joined, and then we got the apical split, you know, down in the apical thirds, filled with, you know, sealer, maybe a little mixture of sealer and GP both there. This was the sagittal slices pre-op and post-op, and you can see the multiple ramifications coming off on the MB root apically. This is the axial slice, and we have the pre-op on the left showing one, you know, you can see the MB there definitely, and then we see this coming off MB1, MB2 canal there, branching off on that. And then I want to show the follow-up. This is the DB and palatal root, same tooth, and you see complete osseous regeneration, 6-month follow-up. Someone was asking on follow-ups. I've got a lot of them, don't show much here today, but I've got you know, a bunch of follow-ups utilizing the laser. I've been using it since 2018. But complete osseous regeneration, palatal root going on there. Another MB2 case here, tooth number 3, and pre-op CT. You can see that there's 2 MB canals there. It looks like there's a little anastomosis going on between the 2 in the apical portion, and then maybe a little bifurcation going on. And you see that the post-op CT, 4 canals treated to their apical extent. It does look like we feel something going on in the anastomosis there. This is a 3-month follow-up going on here. And you can see that we have some osseous regeneration going on, decrease in size of the findings, MB and DB roots. Again, we got the cortical plate being reestablished, and then what we see is the anatomy being replicated again as well, filling of the anastomosis between the 2, and then continued filling of the MB2 canal to the full apical extent. The DB and palatal findings are significant. You can see that the new osseous regeneration occurring there on the DB root, and a lot of new osteoid forming there, and then the palatal root also decreasing in size. So we're kind of going to go through this quick here today. MB2 here, I think I've showed this one here before, but it's basically just the steps that I take. Access into the tooth, it was basically necrotic. First image is right after access, second image running the laser, the coronal conditioning mode, and then after instrumentation running the laser third image, and right before obturation. And you can see how delicate the shapes were and conserved the accesses and everything was again cleaned to the full apical extent. Tooth number 14, this was a calcified brick. Accessed, found 3 canals, and you can see we've got a little MB2 in there as well. We look at the pre-op and post-op CTs here. I did take a post-op on this one. Again, there's a little remnant of an MB2 there. Could not find anything, but it looked like it joined in, and then a single canal, MB canal, to the canal terminus. So we've filled the main one. I did not find any MB2, portal of a negotiation, did not find any of that. Continue to run the tip number 1, the 200 micron right in the canal orifice, and then you can see we were able to backfill that canal, retrograde, and picked up little anastomoses as well. Another number 14, calcified, pretty calcified tooth here, and you can see a little line coming up from off the MB1 up to the MB2. Let's look at the CTs here. This anatomy, pretty crazy anatomy going on this one here. Even if you were to find, I did not find an MB2 on this one, but even if you were to find that MB2 on that one, it dives directly into the MB1. There's almost zero chance you're going to be able to pre-curve and dance back into that MB2 canal here. And we've got a little bifurcation off the MB1 and then that split going on. Retrofilled the MB2 up and orthograde filled the MB2 down. Tooth number 14 had some complicated anatomy going on here. When I took the CT, there was furcal bone loss going on in between there, and gave this patient somewhat guarded prognosis based on the pre-op image, agreed to treat it, and we treated it, and we were able to fill some anatomy there in the furcation. Did not find a MB2 on this one, but again, you can see through activation of the irrigant in the MB1 canal, it retrograde filled the MB2 up, made a little loop, and then orthograde filled the MB2 down there. And you can see based on the CT, we actually see that the pre-op on the left, the little anastomoses between the two. And when you see that, it's good luck getting back into that canal there. This is a 6-month follow-up image. So immediate post-op on the left, 6-month follow-up on the right, showing complete regeneration in the furcation area, decreasing size on the MB and the DB findings there. Another number 14 here, some anatomy present, palatal root. We've talked about patency before, but wanted to focus on the MB2. That's what we're focusing on here. Oftentimes you have that just hard stop at a 14, 15, 12 millimeters, somewhere around there. And a lot of times it's because the MB2 is taking that 90-degree curve right back into the MB1 canal. So when I have that, I'm spending a lot of time activating the irrigant in that MB1 orifice. This case was Monday of this week. So as I kind of wrap this up, tooth number 15, this was on an elderly gentleman. He had trouble staying open. We all have those cases there, limited opening, difficult opening. You can see the immediate post-op there on the right. And this is the CT. I'm gonna show you a little video. Axial slice, looking here. So we're starting at the crown and gonna work down. You can see the MB1. It looks, it's got the root configuration for an MB2. There's the MB2. It finally shows up in the mid to apical third of it. And then it looks like it joins again going down. We're working our way back up. There it is again. And it's gone as we move back up in there. And here is the coronal sections here. So you can see based on the pre-op image, we've got MB1. Looks like there was an MB2 there, but you're gonna do a lot of damage to the tooth if you sit there and hunt and try to drill down and find this one. So filled the MB1 and then we retrograde filled the MB2 through activation of our irrigants in the MB1 canal. Also a few lateral canals picked up palatal root and long kind of real fine spindly DB root as well. So here's my approach to MB2s. I take a pre-op CBCT on every case. You go through it when you're working all the slices, you go through the sagittal, coronal, axial slices. MB2 is not present. good, relax, enjoy the case. That's the rarity, as everyone knows. If an MB2 is present, then I'm making my decision based on two things. Is it separate from the portal of negotiation to the portal of exit? If it is, then I'm going to do my best. I think we all know that you got to locate that one. So do your best to locate that one. If it's not located at the first appointment, I'm closing up. I'm going to put a little, calcium hydroxide right where I was last drilled, and then I take a limited CBCT, have the patient back for a second appointment, complete the case then. Most of the time you can find it that second appointment. Now, if the MB2, based on the pre-op CT, if the MB2 joins into the MB1, I'm going to make an attempt to locate the MB2 and minimally instrument the case. Do not excessively remove tooth structure in trying to satisfy your urge to find that little canal there that joins in. If you can't locate it without iatrogenic damage to the tooth, run the tip 1 in the MB1 orifice and then complete the treatment as you normally would. So that's my approach to MB2s. I'll share one last case. I finished this case up. It's my 3 o'clock case today. And these teeth with blunderbuss apices, any endodontist will say these are hard to gain patency on. And if you've heard me lecture before, you've heard me use the acronym C. What that stands for is safe, efficient, and effective. And that's what the laser is. It's safe, efficient, effective. And you can see from the images here, Craig talked about using the laser to kind of peck his way down. And, can you do it without? Yeah, you probably can, but it makes it more efficient. And that's what I did on this case. I'd use an 8 and 10, followed by a rotary, run the laser for 30 seconds, water. 8 and 10, get, next time I'm further down, 8 and 10, run the rotary, run the laser 30 seconds. Now I'm a little further, 8 and 10, and I just continue that path until I achieve patency. And you can see here, we captured 5 canals in there, all separate portals of exit, vertical canal, everything treated to their POEs. And, that's what I like about the utilization of the laser. Is it 100% necessary? Probably not. I think we can achieve a lot of them, but honestly, it's something I wouldn't want to practice without now. And, when we look at all the technologies that are out now, one of the things that you have to do is you got to look at, no one likes kind of talking about this, but you got to look at the ROI on your practice. And some of the stuff now is just so astronomically high, you got to ask yourself, hey, does that make sense? Now with the EdgePRO, the price point that it's at, I don't see why every endodontist doesn't have one. Where it's at, it's easy to use. It definitely, when you use it, you'll see the inside of the tooth. It looks cleaner, and that's not a bad thing. I think that's a good thing. So anyway, this was a fun, 3-part series here. I thank Chris and Zach for heading this up. And with that, I'll turn this back over to you, Chris.
Thank you, Dr. Moffat. Great case to finish on. I'm not going to let you off the hook that easy. I know the intent for tonight was to focus more on really showcasing some interesting cases, and you guys did just that. So thank you for that. But beyond your technique for breaking through the calcification with your instrumentation and following with the laser, can you talk through on this case here specifically, again, revisit your actual protocol just to kind of punctuate, because I know you've covered it before, but it'd be a nice way to bookend on how you would do this case, inclusive of the cleaning and disinfection phase.
Yeah. So the first thing, necrotic case, open into the case. As soon as I access into the case, I'm using tip number 3, 2 watts, 20 hertz for about 45 seconds to a minute, water only, water's on full blast, and I'm running that. And then I'll drop in a 10 file is what I always start with, and I'll take it as far as it goes. If it goes to, all the way to length, great. But in this case, it did not. So I took it to as far as it went, and then I run a rotary 1 millimeter short of that, 1504 rotary, and then I'm in with my tip 1, 1.25 watts, 50 hertz, and water. I'm just doing water. It's very fast, very efficient. You can use EDTA if you want, and that may help a little bit. But I just grabbed the handpiece. You're toggling back and forth. Assistant's holding it, filing. She's holding the rotary one. I run the laser, hand her that handpiece back. And so you're constantly just doing that. 10 file or 810 file, 1504, 1.25, 50 watts, 1.25 watts, 50 hertz, water, 30 seconds in each canal. And then back to your handpiece until you get patency.
Great. Very helpful. A couple questions here. How can a cyst and its lining be treated or resolved by use of the laser?
Well, I mean, I think that depends on, is it a true cyst or is it a, pocket cyst? And if it's fully encapsulated, surgery is probably the route that you have to go. But if it's not fully encapsulated, if you can go in there and break it up, let the macrophages come in and fully, complete breaking that up, then, I mean, I think some of it is theory right now. And we're kind of seeing what can be done. But, I've done, again, what I call the poor man's Apico sinus tract up there. I'm going with some cotton pliers and you disrupt everything and it seems to heal. But a lot of times we don't even know if it's a cyst or granuloma, or 9 times out of 10.
Charles, did you use dual wavelength technique in any of these cases? How do you determine when to utilize dual wavelength?
I didn't on any of these. I did on a case, I had him back for a 1-week recall today and I didn't put it in here. And I did use dual wavelength on him. It was a premolar complicated anatomy, sinus tract. He was it was 29, he was missing 30, sinus tract came back out of 30. And so I treated that with dual wavelength inside and then outside as well. And soft tissue looked phenomenal today. I guess I don't really have probably ideal would be do it every case. But I'm just kind of picking and choosing right now. The ones that seem to be a little more refractory, I'm doing dual wavelength.
Great. Well, great. Well, I think that's most of the questions that have come through. Do want to take this time to thank the 3 of you, Dr. Maupin, Dr. Anderson, and Dr. Butler, for your time. Really, it's been a great 3-part series. Our intent here was to have something over the summer that we could engage in later afternoon, early evening, certainly balancing both audiences, which involves folks that have incorporated EdgePRO into their procedure, getting started with utilizing the technology, as well as folks that are newly interested in learning more about the technology. It's a delicate balance, right? Because there's so much information and so much of what you're talking about is so helpful to the existing user. They want more, and to the prospect, they're intellectually still very curious. So as we go forward, we're going to look to structure more of these webinars that maybe can separate these audiences and allow us to go deeper into technique, into adjunctive uses of EdgePRO, and really dive into mastering how to incorporate this technology as you all are doing here. So doing that, and then also continuing to provide information to the newly interested who are seeking to incorporate this technology into their practice. But nonetheless, it's been a very successful 3-part series, and thank you all, 3 of you, for participating and sharing your wealth of knowledge and experience. So other than that, I think that's it for our 3rd part, and I wish everybody a great rest of the week and evening, and we'll look forward to staying in touch with you in the near term. Have a great evening. Thank you.
Thanks, Chris.